Hello everyone and welcome back to my channel. So today basically I'm going to give you a quick review of pulmonology and the most important topics in this chapter. So we'll start from sarcoidosis. So basically sarcoidosis is a condition which is most prevalent in the African Americans and usually in young adult population. It presents with constitutional symptoms like fever, cough, dyspnea, chest pain. Now, so there are also extrapulmonary findings associated with sarcoidosis, which could be skin lesions, anterior-posterior uveitis, and Lofgren syndrome, with even something very different that has an association with sarcoidosis, and that's called parotid gland swelling. Now, Lofgren syndrome is a manifestation of three things, which is fever, erythema nodosum, which is basically these are the skin manifestations on the shins and the heel, and bilateral hilar adenopathy. Now, in imaging of sarcoidosis, we basically see bilateral hilar adenopathy. The word bilateral is very important. And then you can see also pulmonary vascular infiltrates. Now, laboratory findings are going to give you hypercalcemia and hypercalciuria and elevated ACE levels. So you send two things for the lab analysis. Now, also important thing is hypercalciuria occurs more frequently than hypercalcemia, and that leads to nephrolithiasis in patients with sarcoidosis. Now again, then in pathology findings, you're going to see non-caseating granulomas that stain negative for the fungi and the acid-fast bacilli. And where do you see caseating granulomas? In the TB patients. Now, a quick review of manifestations of sarcoidosis. So a patient with sarcoidosis with pulmonary findings, bilateral hilar adenopathy and interstitial infiltrates. So what about ophthalmological findings? You're going to see anterior uveitis, iridocyclitis, iritis, or posterior uveitis. What about reticuloendothelial findings? So you're going to see peripheral lymphadenopathy with hepatosplenomegaly. And in the musculoskeletal system, you will see acute polyarthritis, especially in the ankle joints, and then also chronic arthritis with periosteal bone resorption. And we discussed the central nervous system and endocrine findings, which is hypercalcemia, but there's also something called a central diabetes insipidus, highly associated with sarcoidosis. And then we just discussed the Lofgren syndrome, which is triad of erythema nodosum, bilateral hilar adenopathy, and fever, with an additional thing here, migratory polyarthralgias. Now, frequently, sarcoidosis is an incidental finding on chest X-ray. So there's a patient that presented with fever, cough, weight loss, dyspnea, and fatigue. And again, we said that the kidney involvement is usually nephrolithiasis, or the second thing could be interstitial nephritis. Nephritis is the inflammation of the kidney. So you can see interstitial with nephritic changes. In cardiac, what is cardiac sarcoidosis? So cardiac sarcoidosis is that there is myocardial infiltration inflammation, which leads to conduction defects of the heart, which means like there will be AV blocks. AV blocks is the most common. There could be dilated cardiomyopathy, valvular dysfunction, and heart failure. And this can also lead to sudden cardiac death in patients with sarcoidosis. Now, a definitive diagnosis is consistent radiographic and clinical findings, and a biopsy demonstrating non-caseating granuloma. So bronchoscopy with a transbronchial biopsy is often done to obtain the tissue and can be obtained from other sites like skin or lymph nodes. Now, patients with an incidental bilateral hilar adenopathy without the symptoms are monitored without biopsy. So if my patient has an incidental finding with no symptoms, so I'm not going to do a biopsy unless there are symptoms. Now, treatment is like for asymptomatic patients, they're just monitored without medicine. because there is a high rate of remission in this. Your patient is usually going to be fine. There is going to be remission of symptoms who is asymptomatic, but symptomatic patients are treated with systemic glucocorticoids. So you have to also rule out infectious causes of granulomatous disease like TB and histoplasmosis before starting glucocorticoids, because never ever give steroids to someone with TB or histoplasmosis. It's going to be worsened. Now, the second topic that we are going to discuss in pulmonology is a very common disease called as granulomatosis with polyangitis. So it's also known as Wegner's granulomatosis with polyangitis. And I want you to know that there is upper respiratory, lower respiratory, renal and skin involvement. Now, which means that in upper respiratory, there is sinusitis and otitis with a saddle nose deformity. So saddle nose deformity is a huge word that you need to remember here. And in case of lower respiratory, there's nodules and cavitations that you're going to see. So always remember the upper respiratory symptoms in Wegner's, like sinusitis and saddle nose. So remember the nose. And in renal, there is rapidly progressive glomerulonephritis, very important. And in skin, you can see livedo reticularis and non-healing ulcers. Now, there can also be, alveolar opacities that can be seen in this. And what is the diagnosis? The most important thing here is to remember that these patients are ANCA positive, which means mostly it's PR3. 70% of the times, these are the antibodies that are present, or MPO antibodies could be in case of 20%. Now, biopsy will, if you take from the skin, you're going to see leukocytoclastic vasculitis. And in case of kidney, there's usually post-immune glomerulonephritis. And in lungs, there's granulomatous vasculitis. Now, management of this patient is going to be steroids and immunomodulators. And they have also mentioned that rituximab may also be used in such cases. Although we use methotrexate and cyclophosphamide, most of the times I've seen like cyclophosphamide is the drug of choice with methotrexate. So a vasculitis of small and medium vessels, most commonly affecting men and women of around 30 to 50. That's when Wegner's happen. And I just mentioned that upper respiratory tract is the most commonly involved. So always remember the nose and the trachea, narrowing and ulceration of trachea with auditory-canal ulceration. And there can be anemia of chronic disease present in these patients with mild leukocytosis. Now, HIV increases the chance of false positive results of ANCA, so it should be ruled out. So let's suppose I sent my patient for ANCA testing and then ANCA is positive. I would also do an HIV test, because HIV can give you false positive results. Now, patients with clinical symptoms and positive ANCA, you have to start treatment before confirmatory biopsy. You just have to start treatment. In sarcoidosis, we were waiting for the biopsy, to come, because we want to rule out other things in that case. Now, breath sounds on auscultation, always remember what are the normal breath sounds. So they're usually, in case of percussion, they're resonant. What about auscultation findings? So normal breath sounds are vesicular. The word vesicular, very important, they're vesicular. And it means like quiet inspiratory phase and almost inaudible expiratory phase. When you're going to put the stethoscope, you'll hear a quiet inspiratory phase and not an expiratory phase. Okay. And in case of what is bronchial breath sounds? So bronchial breath sounds are louder and have prominent expiratory phase provided airway is patent. If the airway is blocked, breath sounds over the consolidation will be decreased. Now, in case of interstitial lung disease, the fine crackles will be heard at the end of inspiration. So you have to remember the auscultation findings. Now, what is egophony? Egophony is when you ask a patient to say letter E, it will sound as A, because it is like the quality of the sound is changed, and that's usually happening in consolidation. So if you have, where do you see consolidation? You see in patients with pneumonia. Egophony can also be present in pleural effusions at the area of accumulation again, because it's somehow very similar. There is air entrapment, there's transmission of air through that collapsed area. Now let's talk about the pulmonary auscultation examination findings. Now, if you have a consolidation, which I just mentioned, if you have a lobar pneumonia, what are you going to hear on auscultation? So there's going to be crackles, bronchial breath sounds. What were those sounds? They were louder sounds and, prominent expiratory phases. And if it's blocked, then those are decreased sounds. So this is a distinguishment that bronchial sounds, although they're louder and have a prominent expiratory phase, only if the airway is patent. But if your pneumonia is such that it has, blocked the airway, now your sounds will be decreased. Now, bronchophony, egophony, and pectoral equi is heard. The tactile fremitus is increased on the consolidation side. What is a fremitus? So fremitus is basically you will ask the patient to say something, and you will basically feel the vibrations, and those are increased in case of consolidation. In percussion, there's dullness. Fluid consolidation, there's always dullness, and there's no shift, because obviously why there would be any shift? It's just a consolidation. Now, in case of effusion, pleural effusion, there is decreased breath sounds. Again, these airways are kind of getting compressed, so there's decreased breath sounds with decreased fremitus. Fremitus is only increased in consolidation, remember that. And in case of percussion, it's dull, and in effusions, if it's large, it's going to give a mediastinal shift. Okay. And in case of COPD, there is decreased breath sounds, and these are usually vesicular sounds, but these are decreased breath sounds. And there is decreased fremitus. There is hyperresonance if there is large bullous, because obviously there's a lot of air entrapment and there's no shift. In case of pneumothorax, again, decreased breath sounds, and there is decreased fremitus. There is hyperresonance on percussion, and if it's a small pneumothorax, there's no shift, but if it's a tension pneumothorax, so obviously it's going to be shifting, pushing the mediastinal, there's going to be mediastinal shift. So now sound, travels faster in solid. We all know that, and hence fremitus is a palpable vibration, as I just mentioned. So consolidation would lead to bronchial sounds due to basically over transmission of the sounds of the chest wall, and that's why we are saying that in this case you have bronchial breath sounds are going to be there. Now let's talk about